Hello, welcome to Pharma Television News Review here at the 4th Midkine Symposium in Budapest in April 2016. On this show, I have Dr. Victoria Campbel, who is at the Sunshine Coast Institute of Critical Care Research in Queensland. Welcome.
Thank you.
Vicky, your area of research and interest is in the area of kidney disease. And what's important, I think, about you as an individual is that you're a clinician. You're actually dealing with patients who undergo all the problems of kidney disease, particularly in the area of acute and chronic kidney disease. So could you describe to our audience just a little bit about those type of patients and the issues that you see as a clinician?
Yeah, so I work both in intensive care and in the nephrology chronic kidney disease area. So acute kidney injury from an intensive care perspective is my interest, and I guess the issue is for the patients that I see, particularly in the clinic with regards to chronic kidney disease, is that they have a progressive disease, many of them, that despite controlling all of the risk factors that we can control, we have no other treatment once it gets into the relentless progressive stage. So for me, the opportunity to do some research into finding ways to slow or arrest that process was very important. Right,
indeed. Now you talk about the progressiveness of the disease. First of all, the patients themselves are susceptible to this because of their another underlying problem that they have, and that's usually what?
Yeah, so the most common cause in the developed world of chronic kidney disease now is diabetes, and essentially diabetes, hypertension, and vascular disease really are the primary causes. Once they get diagnosed with chronic kidney disease, the goal is to optimize sugar control, optimize blood pressure control, cholesterol, all of the cardiovascular risk factors. And then, as I said, once that's done, all you can do is sit and wait and hope that things stabilize.
And of course, diabetes is a growing problem. So
yes, enormously.
So the area you're in is actually huge.
Yes.
So with your observations of these patients, and as you described, the progressiveness of the disease, there are certain things that are missing. Obviously, the ability to monitor them. I suppose you can monitor them to a certain level, but there are no specific biomarkers that you can pick up at least when you started this research. So, So could you describe what that issue is a little bit more detail, and why you've now got deeper into this? And probably where Midkine comes in.
Yeah. So basically, both with acute kidney injury and with chronic kidney disease, because a significant proportion of the patients that get either one of those insults may not progress. So with acute kidney injury, we know from available data that at least half of those patients will recover and regain normal renal function and not have a long-term problem. And with chronic kidney disease, we know that at least half of those patients, depending on which stage they are, once you control their risk factors and remove the the toxins and things, that they will stabilize. So it really is probably less than half of each group that will ultimately develop a clinical or a progressive problem and go into the risk of developing end-stage renal failure and needing dialysis or dying. So when we look at the trials that are available to look at therapeutic targets for either of those areas, we have no way of knowing who the progressors might be. So we end up recruiting a lot of people who are not going to benefit from the therapy.
Indeed. So what's the segue then to Midkine?
So Midkine, I think, has two potential roles. One is as a biomarker, because it does seem to be associated with the progressive component of the final stage pathway of chronic kidney disease, and then also as a therapeutic target, because as I said, at this point there is no treatment option once the kidney disease progresses to that stage.
Right. So how can you join that observation about Midkine and to the underlying disease itself?
So what we know about Midkine is largely from animal studies, which is those preclinical trials that all therapies have to go through, and the animal studies in kidney disease, chronic kidney disease models, are very convincing that Midkine plays a pathogenic role in those processes. And through Midkine knockout mice and so on, we know that it greatly ameliorates the tubular loss, glomerular loss, proteinuria, fibrosis, and renal function is preserved. So it's very convincing from that perspective. We have now, there's very little data in humans with chronic kidney disease, but we've looked at 200 of our chronic kidney disease outpatients to see how the Midkine levels are related in humans. And we certainly found that beyond, once their GFR drops below 60, they have a function-related increase in Midkine levels. So these patients are being exposed to very high Midkine levels in the long term once their kidneys are failing.
Right. I suppose, I mean, obviously, clearly difference between doing mice studies and human studies. In particular, as you say, the progression is a slow process anyway.
Yeah.
So this is long-term research to some extent.
Absolutely.
So in the end, looking at the potential for Midkine, you mentioned it as a potential biomarker. You also talk it from a therapeutic point of view. Could you just give us a little bit more on that?
Yeah.
How you see those two?
Okay. So
from
a biomarker perspective, Midkine in humans, being a little bit more complicated than in animals, I think probably has more of a role as a marker for those who are going to progress. When we look at the search for a biomarker to identify acute kidney injury, the idea is identifying acute kidney injury early so that it can guide treatment, fluid management, and toxin avoidance and things like that. But at the end of the day, a biomarker that tells you which ones of those patients are going to progress is probably more valuable. And in the acute setting, when in humans, the predictable acute setting injuries are in relation to ischemia reperfusion injury associated with cardiopulmonary bypass or clamping of large vessels for vascular surgery. And those are done usually in the setting of using heparin, and Midkine being a heparin binding molecule goes up in the serum when you assay it. With the administration of heparin. So knowing what that biomarker means in the setting of heparin, in the setting of reperfusion, and the fact that it moves on and off the vasculature makes it complex to use. But in the chronic kidney disease population, there definitely an association between Midkine levels and driving a pathological association and driving that fibrotic process that's happening at the end.
Right. And when we're talking about Midkine levels, we're talking about Midkine levels in urine, in serum?
Yeah, serum and urine.
Right.
Both have been looked at. When you look at the chronic kidney disease population, it is both the serum and the urine levels that go up.
Yeah.
In the group that we looked at, there are people who have the urine levels are significantly higher than they seem like they should be for what the serum levels are, suggesting that there is some intratubular secretion and production and secretion of Midkine, which would be consistent with what the animals suggest is part of the driving pathological injury.
Right. And then just on the therapeutic, how would you visualize the treatment protocol? Potentially.
Yeah, potentially.
Still,
that's right.
Still early days, but yeah.
Look, I think that as far as the treatment goes, what we'd be hoping, I guess, is that Midkine could be a biomarker for its own efficacy. So if we could have a situation where you have a patient who has elevated serum Midkine levels and you administer the antibody and you see those levels come down, as we've heard in some of the bone research today, and that the Midkine levels coming down is associated with some hard endpoint improvement, then that would be the ideal, because then we could create a currently unavailable surrogate, I suppose, for the response to the treatment. The other problem with chronic kidney disease research, however, as you say, I mean, it's a long-term thing. The changes that we see are really looked at. Progression is described as GFR deterioration over 1 or 2 years. So a number of the studies that have been done to date have been really 2-year treatment plans, and this would be a maybe 4 to 6 weekly antibody administration over that time, and then looking at in an ideal world, the hard endpoints rather than the surrogates, which again makes the sample size that you need significantly larger if you don't have a biomarker to guide you.
Indeed. So all fascinating, really, and a lot of potential there.
Yeah, absolutely.
Vicky, thank you very much indeed for coming on the show.
No worries.